This is a rare disease. So I would always advise my colleagues in that community to seek for a second opinion. I think that in a lifetime, and there is studies about that, um, a community physician looking at cutaneous T-cell lymphomas, they could see as much as one case per year, or sometimes even one case in their career. That makes them sometimes not, I don't think that incapable, but non-comfortable with certain treatments that sometimes have certain side effects. For instance, when we recommend people to get mogamulizumab, which is a drug that we commonly use in cutaneous lymphomas, sometimes the challenge they face is first, they don't know how to get the drug approved. And many times if they get it approved, they don't know the side effects that many times is something that doesn't necessarily lead to stop the drug, but instead to looking into the differential. This is progression, or this is just basically a side effect from the drug that could be managed just by holding the drug for a few days or using creams or something that could be managed. So my first tip of advice, regardless of the color or where you located, it would be always good or wouldn't be bad to seek for a second opinion in an academic center, in a center that has the capability and experience to co-manage, because the patient, again, as I said, there's a lot of barriers to getting patients to big academic centers because they are located in usually big cities, but to co-manage them and we communicate each other about that. That's, for example, something that I practice in my clinic. I have a huge list of telephone of all people in the community that I always tell them, just to talk to me if there is any challenges you face. Now, going into people from color is many times with them, the challenge again is that how do you stage the disease? How do you know patients are responding and not responding? Because unfortunately, one of the real things is that it's difficult to know what's happening in people with color when you're managing skin cancers, specifically cutaneous T-cell lymphoma. So my recommendation will ultimately go to the same, to have two people, one managing locally and one managing in an academic center, that can assess the patient over time, especially if there is a concern that the patient is getting more symptomatic despite everything you're doing. And what we do usually is that most of the time patients go to their community doctors every 2 or 3 months, and they see us once a year. And that way we can have a multidisciplinary management in which we know what's happening over time to that patient. Another thing that I would recommend is to, even though it takes a lot of time from people in the community, for which MD Anderson, for example, has the resources to do, is during their first meeting, the patient usually see that one day they are there, they see a dermatologist, they see a radiation oncologist, they see our social worker, they see a transplanter, and they see a lymphoma physician. So only there, I'm telling you, there is 5 people on board in their care the same day the patient comes. So the question sometimes comes like, can they have the same care, looking at the same amount of people involved in their care in the community? And the answer is many times it's very challenging for them to do that. So another piece of advice will be that one, to have always a multidisciplinary team involved in this patient's care, because sometimes what is flagged as patient non-compliance is usually not related to non-compliant. It's just that patient cannot just commit because of the treatment, because of the transportation. So, and that's what the social worker, for example, gets very, very involved from these patients, and they are always involved with these patients. And the last thing I would say that I would recommend to providers in patients with color is always, if possible, if there is any concerns on these patients in regards to treatment, or maybe the patient is not following the directions, to make sure that they are understanding. Many of the people or Latino people, for example, that comes to the United States, they lack literacy about what's going on, especially in rare diseases. And also because, at least in the United States, and that's something that we're trying to change with partnership with the Lymphoma Research Foundation, there is not much things in Spanish that, for example, patients can read and trying to understand. For example, with Tim Fraley, we have been able to get this information out in Spanish, for example, from mogamulizumab. And that has definitely helped the patients that I treat that are Spanish speakers to provide information that are within the language they speak. And many times also it's important to remember that sometimes this patient also do not really know how to read. and you have to provide audiovisual things that can help them. So my summary of this is there is many factors that affect the patient's care. And one of those could be the fact that the patient just doesn't understand what's going on. So a big piece of advice for me is if you are noticing that what someone is expecting to happen as an outcome is not happening or not being delivered, to make sure also that the patient is on board, that he understands that what the process is being and what the goal is, because it's important for them to set up goals so that way they know how things should be looking at. And knowing that this disease many times requires multiple treatment options in order to lead to a very good outcome. Sometimes patients, it takes them like 3 or 4 treatments to just start seeing that things are changing. So that could be very challenging with someone, and I'm saying this as an Hispanic descendant, that someone for us is difficult to understand that we are in a big country, we are in the #1 world cancer center, and things are not changing. But it's not that. It's just the biology of the disease is very challenging.